Talk first and then go to Mark.
Hi, my name is Claire O'Donnell. It's a great privilege to be part of this Pediatric Cardiac Society of India meeting. I wanted just first of all to acknowledge that we're all facing this issue with the global pandemic and how much I have enjoyed my previous trips to India. I have some great friends in India and I look forward to the days that we can all be together again. Just to start, I wanted to spend a moment just reviewing the physiology of pregnancy because this as cardiologists is something that we may not be familiar with. And obviously pregnancy makes big demands in terms of needing a large increase in cardiac output. This tends to happen through the first trimester up into the second trimester and is achieved through a combination of increase in heart rate and increase in stroke volume, with a fall in total peripheral resistance. There are further demands around the time of delivery, and importantly, everything doesn't reset immediately the baby's delivered, but we need to watch our women, particularly those with more complex cardiac problems, through those early weeks postpartum as these changes gradually reverse themselves. As we are able to offer more to children with congenital heart disease, we may well find ourselves with more women with congenital heart disease reaching ages where they desire to have a pregnancy. And I think it's very important to say that, of course, we don't face this challenge alone. We need to cultivate a team, and in particular, that team needs to include close collaboration with our obstetric colleagues. Some of you may be lucky enough to work in settings where you have physicians with an interest in pregnancy and obstetric medicine, and particularly around the time of delivery, our anesthesia colleagues, again, particularly for the more complex women, are vital. Our role in this team is obviously a very careful pre-pregnancy and early pregnancy assessment, but then intermittently reviewing progress with our women as they go through pregnancy and communicating our assessment to the other people in the team. A couple of things I think are really important here. First of all, as you know, in congenital heart disease, we have our own language in terms of the way that we communicate cardiac defects. But for the average obstetrician, this may not be clear at all. And I have often found myself in meetings grabbing a pen and drawing a picture on a whiteboard so that people can get to grips with where the hemodynamic compromise may occur in somebody with a particular type of congenital heart disease. Are these right-sided issues? Are they left-sided issues? Are they a combination? And I think if we put our heads together with these people who understand pregnancy physiology well, then we come to better conclusions for our women. And the other thing to say is, of course, the importance of careful documentation. Women are going to deliver at some predictable time, and we may well not be standing next to them when they go into labor. So we need to risk stratify, and then we need to communicate and make careful plans that are written or electronic so that people can access those to try and deliver the best care. I won't labor the pre-pregnancy evaluation because this includes many of the things that are in our standard cardiac evaluation, but obviously important to look at medications. And we do like to look at cardiopulmonary exercise testing in women thinking about pregnancy, although sometimes I am talking with women who are big into exercise or have very active jobs, and I know that they have an ability to increase cardiac output, and I get some reassurance from that. Of course, we should be starting these conversations with our adolescents, with the girls as they come through, and then the young women, and including information about pregnancy and also obviously about contraception where required. Important also to recognise that we're not just talking about obstetric risk and maternal risk, but that many women, particularly with more complex congenital heart disease, these scores also need to capture some element of the fetal risk. And these risks particularly are around babies' increased pregnancy loss and prematurity and babies being born small, and the inherited risk of congenital heart disease. A more difficult conversation with women and their partners is around the impact during childhood, the childhood of this baby, of a major change in the health status of the mother, or potentially even loss of a parent in childhood. But I think those difficult conversations are important for people to understand. So coming to the specifics of risk scoring, there are a number of scores around. I'm going to talk mainly about the WHO score and the CARPREG-2 score. But at the outset, we need to recognize there are real limitations to our current scores. When we are thinking about using them, we need to think about where they came from. Is this patient similar to the population? Were there many women with congenital heart disease in the population from which this risk score was developed? And also, was this risk score developed in settings that are similar to my own? And then thirdly, is this about maternal cardiac obstetric risk that we're scoring here, or is there some component of fetal outcome scoring included? And when I talk about pregnancy, obviously optimally, we might be having a conversation well in advance of pregnancy with a woman, talking about what pregnancy might mean for her. But sometimes we know that women present in early pregnancy or even well into pregnancy. And the scoring can be helpful, but probably at that point, if she's going to continue, we need to sort of just deal with things as we find them. So just introducing you to this modified WHO classification, which I think is still useful and goes from 1, being a woman who really doesn't face any increase in risk, to being 4, where the woman is at very high risk. And essentially, we would consider that pregnancy is contraindicated in this group. And I think this is a useful exercise to think about WHO scoring, but we will find that majority of women in whom we are trying to think about risk scoring will be in this 2 to 3 category. And I think this is a bit muddier because there's quite a difference between being a woman who is firmly in class 2 to being a woman who is in the higher categories of class 3. And I'm just going to illustrate this. This is from the same paper. But obviously a small duct, you're in WHO 1. But if you've got tetralogy of Fallot, you might have a good repair with good right ventricular function, or you may be someone where there's been a long-term impact of pulmonary regurgitation, there's substantial tricuspid regurgitation, the right ventricle's not working well, you've got rhythm problems, and obviously then you're moving more into class 3, which would include more people with more concerning things like mechanical valves, systemic right ventricles, single ventricle palliation, and cyanotic disease. I just put this up. Fortunately, WHO 4 is a relatively short list, but some of you may see a number of these women who have substantial pulmonary hypertension, very poor ventricular function, or severe outflow tract obstruction at the mitral aortic valves, or coarctation, or a very big aorta. And obviously we're at very high levels of maternal risk in this group of patients. Just to illustrate a little bit in my practice how this works out, a couple of recent registrars wrote up our experience over the last 10 years or so. Fortunately, in that cohort, we had no maternal mortality, but as you can see, we did have a fair amount of morbidity. And in fact, this focused, we looked at this group around largely babies being born early, babies being born small, needing to go to the NICU, and obstetric issues, including prominently postpartum hemorrhage. And if we look at our women, this is how the MWHO class looked over the group of women that we reviewed. And you can see for cardiovascular risk to these women, actually, it worked fairly well. But interestingly, even in some of the WHO class 2 women, there was a significant amount of obstetric and neonatal morbidity. All of the MWHO 4 women, interestingly, ended up with cesarean section, although in most women with congenital heart disease, we would be generally considering that vaginal delivery would be a safer mode of delivery, but all of the class 4 women, which included quite a number of Fontan patients and also some people, a small number of patients with pulmonary hypertension. The other score that I think is really useful is the CARPREG-2 score, and this was obviously based on the original CARPREG score, and I won't read out the different factors here, but they include some anatomic factors, some more physiologic factors, and also, interestingly, other factors like women who present late for that first assessment. And this was validated in quite a large group of Canadian women. And you can see here how perhaps the CARPREG-2 score can be used to further risk stratify women amongst the various MHU classes, and this is incidence of maternal cardiac event from this validation data set. Some of you will be familiar with the big collaboration of the ROPAC registry that looked at more than 2,000 women with cardiac disease in pregnancy and included, I think, about 60% women with congenital heart disease. And you can see here how the MHU class separates out levels of risk in this group of women. But interestingly, there were quite a few women included in ROPAC who were from emerging countries, and you can see some differences here in the risk stratification, particularly on the bottom there. If you look at how this risk stratifies women with congenital heart disease amongst women in different settings. I would recommend this paper to you. I think it's a really nice review of risk stratification published in Heart in 2020. And what it does quite nicely is bring together different scores and point out the different predictive events that have been, predictive factors that have been highlighted by different scores, which lead to these elevated event rates, particularly cardiac event rates during pregnancy. So I think that's a very nice review. There have been attempts in different populations and different settings to try and look at these scoring systems. And again, these have basically focused mostly on the CARPREG score and also on the WHO score. And I did look a bit to see what work I could see from India. I came across this paper from South India, which just reminded me that as we have in this country, obviously a lot of you who care for women in pregnancy will still be seeing a lot of rheumatic heart disease, which is not the focus of this talk, but is obviously quite a substantial issue. Don't forget modifiable risk. So in terms of lifestyle factors, this is really important. And also thinking about women in that pre-pregnancy time, particularly those who face some elevation in the risk of cardiac event in terms of whether cardiovascular intervention in that pre-pregnancy period may make them safer candidates going forward for to undergo a pregnancy. And just the final thing I wanted to say, this is quite a nice guideline, again, a few years old, but from the European Heart Journal, walking you through risk assessment and risk estimation, but then focusing, of course, on informed decision-making with women, recognizing patient autonomy, which is, of course, a very important factor here, and also the role of patient education, both in terms of those who are keen to embark on pregnancy and also women with congenital heart disease who wish to avoid the risks of pregnancy. I think all of these steps are important. So just to finish, I think collaboration with our colleagues is good and vital. I think planning is good and vital, and structured risk assessment, I think, is a useful tool, even with the limitations of current tools. But I think using these tools in combination, particularly the WHO and the CARPREG-2, I think is probably what I'm finding most useful in practice currently. We need to do our careful pre-pregnancy assessment. And then if a woman is going to embark on a pregnancy, obviously we have quite a bit of planning right through to the postpartum period to think about. Just a brief advertorial before I finish. Those of you who belong to the International Society of Adult Congenital Heart Disease will have come across the new website, which has a great forum portal to ask clinical and other kinds of questions, and I'd really recommend that to you. And as it's the middle of the night, I am not going to be up to answer questions, unfortunately, in the forum that follows these talks, but you are very welcome to email me. I'd love to hear from you. Take care now.